Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, the head of marketing here and your host for today. Our topic is the 2021 Final Rule for the Quality Payment Program from the Physician Fee Schedule. Our team has spent the last couple of week or so digging into all those pages and saving you the headache of having to dive into all of that. Before we get started here, just a few introductory comments. Mingle Health is proud to be your trusted partner in the transition to value-based care. We help you improve what matters by guiding you with technology and advisory services to help you not only improve your quality scores, drive practice improvement, but also help your bottom line. And we're proud to have been in business since 2012 and trusted by more than 75,000 providers across the country. Next slide, please. As you know, we are a qualified registry. So our team is getting ready for what we call internally the submission season, but for what all of you are doing, which is diving into all your end of year performance, while trying to juggle all of the COVID-related pandemic response. And so we are grateful to all of you who are doing whatever is necessary to respond to this pandemic and keep people healthy and to save lives. And with the good news of the vaccines rolling out, we don't know exactly what day to day is going to come in 2021, but we are here to help you. And we hope to take the burden of this program off of all of you as you are focusing on your patient care. If you do need a vendor for 2020 or 2021, please do keep us in mind. We are here and excited to partner with you in this work. Jump to the next slide, please. A few announcements before we get going. This webinar is being recorded, so we encourage you to ask questions throughout the webinar in the chat box. You can download the slides now in the handout section of GoToWebinar. And this session is also being recorded, as I said, so we're going to send that out via email later this week and post it on our blog as well. A couple upcoming events to keep an eye out for. We're going to dive in specifically in early January after the new year, looking at QPP participation for large organizations, ACOs, and alternative payment models, transitioning away from web interface. That's a big element that's in the final rule that we're going to speak to today, but we're going to dive in specifically for looking at what that looks like in January. So keep an eye out for that. The other thing that we're excited about is January 1st, 2021 kicks off the first performance year for the primary care first payment model, which is brand new. So Roxanne Thacker is the head of that program here at Mingle, and she's going to share with you how that program compares to CPC Plus, which we know several folks have been participating in. And there is the anticipation that CPC Plus practices will be able to join the Primary Care First program as the second cohort in 2022. So we want to share with you what we're learning about kicking off those first practices that we are supporting with qualified registry service, as well as advisory services to help with patient engagement and attribution and HCC scores, all kinds of stuff to dive into. And look for our familiar content on diving into what it takes to succeed with MIPS in the next coming year. Our team is preparing all the little ins and outs of what you need to know about the program. One big thing that we're seeing is that there's a lot of changes to quality measures this year. Dr. Mingle is going to touch on that in this webinar, but we'll be diving into that in follow-up content to help you make sure that you're aware of what's happening. So with that, I'm pleased to introduce you to our presenter today. Dr. Dan Mingle is the executive chairman here at Mingle Health and a family practice physician, as well as tons of experience with health systems and quality management and value-based care across lots of different organization types. So with that, Dr. Mingle, over to you for today's presentation.
Thank you, Charles, and thank you, everyone. Good afternoon or good morning, depending on where you're logged in from. It was an interesting rule this year. A lot of things I'm excited about. Not a ton of changes in the dynamics of MIPS. So we're going to just briefly touch on the final rule, then looking back a little bit, some of the experience in MIPS so far, highlights of what hasn't changed, a quick trip through that, and then get into the important parts of the MIPS scoring and performance categories. We'll touch on MIPS value pathways, which we've seen coming for a couple of years now and still isn't here, except for a sneak preview with the APP, or the APM performance pathway, which is modeled after MVPs. So with that, without further ado, let's touch on this. If you open up the slides, you'll find a link to the final rule here if you want to see it in its full 2,000-page majesty. It's not formally published yet, and you can tell the difference by the formatting. It keeps me from publishing page numbers references, because those will all change when it's formally published on the end of the month. Interesting, everything is compressed this year. The final rule was a little late coming out. They gave a little late, a month late being published. And the final publication date of December 28th is just 4 days before the start of the year, January. 4 days, 3 days before the start of the year, January 1st go live date. Law requires 30 days, but the pandemic let them be a little more lax. Some of the new rules go into effect for this current submission year. So I'll call them out as we see them. Participation rate seems to have stabilized at a very high participation rate. The low volume exception has stabilized. And now we're seeing a growth that we'll continue to see year by year as population grows. We saw that in the PQRS, and now we'll see it in MIPS. There's almost universal participation, although that's a bit of a sleight of hand. 65,000 providers were granted. If you didn't send in a submission for 2019, you were granted automatic extreme and uncontrollable circumstances. So the mystery I see here is, how did 900 providers not get credit for the submission or for the year? So performance is still excellent across the board. We're still living in that mythical society of Lake Wobegon, where all the providers are above average, except 84% in 2000 for the current payment year. That's 2020, which was the 2018 reporting. 84% were in the positive range. Or were exceptional performers. 97.55 were in the positive range. We're going to have to see these negative performers, negative adjustments go up if there's ever going to be much of a incentive for those who are performing and working at great performance. There's no change in eligible clinicians from 2020 to 2021. There's no change in the low volume exclusions or the opting in policies. There's no change in the quality scoring 3-point floor. It's still 3 to 10 points for a class 1 measure where there is a benchmark. You get your minimum 20 patients and you're hitting your data completion criteria of 70% of all your, at least 70% of your eligible instances, and all payers. There's still a 3 points for the measures that don't have a benchmark or you don't have 20 patients to report. And small practices are still getting 3 points for just a small effort at putting in the measures. Facility-based is still going strong with no changes in that. If you have any of the special statuses, low volume, non-patient facing, hospital-based, small practice, ASC-based, you can still find those statuses at qpp.cms.gov. I mentioned data completeness criteria, no change. It's still at 70% where it went for the 2020 year. All payers, unless you're doing claims or web interface, in which those are Medicare only reporting. A lot of the language in this year's rule points out that we're now in overtime for many policies. There's a lot of things they're doing they did not intend or do, and still do not intend to do permanently. Things like the high priority measures bonus, end-to-end electronic reporting, the quality improvement bonus, the complex patient bonus, 3-point floor, and remembering that the $500 million exceptional performance bonus is due to end after the 2023 payment year. So that means this coming year is the last year, this coming performance year is the last year that you can participate in that exceptional performance bonus. Although I'd say now that's the only one of these rules that's set by legislation, so Medicare doesn't have the authority to extend it. I wouldn't be surprised if some legislation does extend that, considering all the delays we've had getting up to full speed on MIPS. They are on the 3-point floor. They are promising to return or threatening to return us to a 1 to 10 point range of scores sometime after we're used to the MVPs. All right, so what's new in 2021? Here's the numbers you're all been waiting for. For one thing, extreme and uncontrollable circumstances applications for this current performance year have been extended to February 1st. So it's not an automatic EUC exception for COVID, but if you can coherently express a reason why COVID has made it difficult for you to participate, you can still put an application to be forgiven from the participation this year. This is on the right, payment adjustment curve for the year. You find your performance level on the horizontal axis and read your adjustment from the vertical axis. This is Medicare's estimate at 5.3 approximately, what they think the maximum positive adjustment will be. But if you remember, in all these years past, here on the left is a table comparing all these numbers year to year. Medicare has always predicted something more than what's actually delivered. So let's see. The years we know about are the 2019 performance year, which was the 2019 payment year, which was the 2017 performance year. And we're currently being paid in the 2020, which was based on the 2018 performance year. And we know that for 2019, the maximum incentive was about 1.8%. I expect 2020 is probably going to again come in around 2% or a little bit higher, perhaps. That number around 1.8% represents just the distribution of the exceptional performance bonus. There was essentially no negative adjustment that contributed to that for those years. We're seeing that the performance threshold is up to 60 and is projected to be by the next year, the following year, the 2022 performance year. It has to be set at either the mean or the median of the scores expected for the year, which Medicare expects to be about 74. That's about it for that. Here we go, the performance category weights for this coming year, 40% for quality, 20% for cost. So quality is a little lower, cost is a little higher. Promoting interoperability and improvement activities at their usual 25% and 15%. And the bar chart on the right shows that historically, shows that balance. Now the 2022 levels, that's still a year away. that is the cruising speed. That's where we expect to be long term at 30, 30, 15, and 25. Complex high-risk patient bonus. Because of COVID, they're assuming all of us are affected by COVID in some way or another. So and rather than calculate anything more specific, they're just doubling the high-risk patient bonus for everyone with a cap at 10. It goes to the final score. So even if you don't have, if you're not taking care of hospitalized patients or other severely ill, you're still dealing with at least the fear, concern that these symptoms might be COVID and things like that. Quality measures. There's going to be 209 measures in the inventory this year. 11 measures have been removed. 2 measures, administrative claims measures, have been added. Hospital-wide readmissions is just a redoing of their readmissions measure. Mostly it ascribes the responsibility for those to 3 providers: the provider that takes care of the patient, or the provider group that takes care of the patient in the hospital, the provider or group that discharges the patient, and the provider or group that follows the patient or long-term afterwards. It's the primary care provider. They think each can help prevent those readmissions, and they're ascribing to all 3 of those now. They're also adding a complications of total hips and knees at a 25 case minimum, and that's the first measure that has a 3-year sample period. And we'll only we're expecting all measures that you actively report to remain a 1-year time, but they claimed the right as Medicare to for those measures that they calculate to alter those measure timing. 113 measures have substantial changes. What Medicare considers to be substantial changes are a number of things, including additions or subtractions from the CBT or ICD-10 codes in the performance specifications. The ones that you really need to pay attention to, if you're doing hemoglobin A1Cs, that now has strata. Less than 7, 7 to 8, 8 to 9, as well as the classic over 9. Depression screening has some tighter specifications for appropriate action and timing for that. Oh, there's also I didn't write here, but the smoking measure, they're tightening the look back to just 1 year, not 2. There have been a lot of changes in specialty measure sets, a measure added here, measure taken away there. So if you're depending on these, be sure you check the specs to make sure you check the list to make sure your measures are still on it. Because of the measure changes, be sure you check the specs to make sure you're still recording it and measuring appropriately. They were proposing some COVID adjustments, anticipating a poor submission of data for 2019, but they had plenty of data, so they're not going to be basing benchmarks on the 2020 submissions. They will go back as usual to the 2018 benchmarks and use those. Topped out measure points were going to be capped, but they aren't. They're just continuing to use their usual topped out measure protocols. I mentioned the 2 administrative claims measures, so I don't need to go into that anymore. Promoting interoperability for 2021 still requires the unscored security risk analysis, so be sure you get that done if you haven't already. It's a little time to do it yet in this year. Oh, excuse me, I'm talking about 2021. So you got plenty of time to get your security analysis done and acted on for the 2021 performance year. The query of prescription drug monitoring program, PDMP, is still optional. It's still by attestation, so you need to do it at least once. It can be manual. It doesn't have to be automatically put into your EHR. It's now worth 10 bonus points. HIE 4, that's the Health Information Exchange. There's an incoming, there's an outgoing variety. They've changed the wording on the receiving and reconciling health information, putting emphasis on their desire to see that meds, allergies, and problem lists get reconciled. Your lists get updated. If there's confusion, that the patient gets alerted to that confusion. Believing that it will help stop readmissions. The clinician types eligible for reweighting of promoting operability haven't changed, and the policies haven't changed. If you're eligible for reweighting, but you make a PI submission, you get scored on the PI submission, essentially. And they're finding that a large proportion of these excluded providers are making submissions. So look for that policy to change at some point, that they'll have the same requirement as everyone. Probably the non-patient facing providers will continue to be excluded. The data completeness policy, we've been enjoying a minimum of, minimum of 90 consecutive days of data to submit. So far in the MIPS program, they've made that permanent. They think 90 days is enough to see, and also it gives you a little freedom around upgrades that you can choose to submit on the old or the new system. If there's a requirement for the year, you don't have to comply with that requirement until the last 90-day period, so about October 4th onset, and you'll see that in another rule. The two measures in health information exchange in promoting interoperability are measures 1 and 4, sending and receiving patient messages. They're adding another option. Those two original measures are each worth 20, still worth 20 points, but there's another option. You can get the whole 40 points for a bi-directional HIE implementation. So it's by attestation. You're not measuring anything, and you're attesting to that you're participating in your health information exchange, that it goes into the EHR, it crosses administrative lines, so it's not just one organization that's using it. It crosses EHRs. There's no exclusionary policies, and you're using the functions of your EHR to implement that. You're not eligible, as you are with some of the registry participation. You're not eligible if you're setting it up or waiting connection. It actually has to be working to be applicable. Now, the 21st Century Cures Act, you may have heard about it, was signed into law in 2016. It resulted in rules from Medicare that were published in 2020. It requires some development by your EHRs that don't have to be in place now. They're extending the deadline to December 31st, 2022. So still 2 years away from that, and since you have to be using the current 2015 edition certified EHR, you will have to have the new functions live in your environment by the end of 2023. Considering the development deadline is December 31st, 2022, you have until the last 90 days of December of 2023 to actually show that you're using it. Improvement activities. They're removing just one activity because the program is no longer in existence, the Patient's Hospital Engagement Network. They made some clarifications to the COVID-19 improvement activity. That is, if you are participating in a trial related to COVID-19, or you're contributing data to a registry that can be used for COVID-19 research. But those haven't changed in intent, but they have changed in wording somewhat. They've extended the call for activities timeframe to from February 1st to June 30th a longer periods annually. During a PHE, you're allowed to submit anytime. And they've made it open season for Health and Human Services to nominate new activities. They're still insisting that all, even the HHS nominations, go through rulemaking, other than emergency issues like the COVID-19 IA. They're also adding a new criterion, considering their efforts to bring MIPS value pathway live. They're asking you to look for improvement activities that can be linked to existing and related MIPS quality and cost measures. You'll be able to find a nomination form for activities on qbp.cms.gov. Cost, there's no new episode or cost measures. They're just going through all the specifications and making sure they include the telehealth and other communications-based services, communications technology-based services, make sure those codes are reflected in the specifications. There are new specifications and audit rules. All the everything that you submit, not just quality, but PI and IA, all need to be audited. Your vendor has to be participating in those audits. It has to be done before submission. So it's you can beware that there'll be a little bit more burden on you around audits, as there is burden on us around audits. MIPS value pathways, they're taking another year delay. They're saying it might come out in 2022. That's the earliest it can come out, but they're also creating an expectation that it could even be delayed beyond that. They've put more details, more dreams around what the MVPs are going to look like. A little more, they've put a nomination for MVP, that the MIPS value pathways measures and groupings on qp.cms.gov. They're declaring their intent to allow subgroup level reporting. So if you're a large multi-specialty group, your cardiologist can submit something different than your rheumatologist, than your primary care physicians. So watch for that. And they want to be able to include QCDR measures in MVPs. So that's enough about MIPS. I think we've covered all the important pieces. There's a bit about alternative payment models. Remembering first that there's been a bit of a change in the vernacular, the vocabulary over the last couple of years. If the term APM is used, that's assumed to mean advanced APM, and the MIPS APM is the one-sided. There's gain only, but no or negligible loss financially in the MIPS APMs. The APMs considered advanced for 2020, they listed and essentially stayed the same for 2021, except I singled out primary care first. I didn't see that in the list, but as far as I'm aware, there's been no change to the plan to bring that live in the first cohort in the first part of the year. Quite excited about that program. So if you're a primary care first, if you're you can no longer join the first cohort of primary care first, but if you're a current Comprehensive Primary Care Plus, CPC Plus practice, you can apply for the next cohort, which should start a year from now. There's some COVID-inspired policies in APMs. First, they've allowed ACOs to extend their period by 1 year, by and large. ACOs in the glide path can stay at their current level for an extra year. They didn't accept any new agreements for a year. They're removing some payment. They're removing COVID payments, COVID-19 expenses from the episodes of care from their program cost calculations. And they're doing that by by eliminating all expenses in the month that a patient is admitted, all the expenses that in the month that a patient is discharged, and another month for recovery, removing that both from the denominator and numerator, so you just average in your non-COVID expenses to set your cost. Now, I'm not certain that that may be applied also to the cost element in MIPS, but I couldn't find specific reference. They mentioned it in the APMs, but I didn't see it listed for MIPS, but we'll wait for the public-facing documents to come out to see if that's showing up. They're expanding the definition of primary care services for beneficiary assignment. They're doing that both in MIPS as well as APM assignment to make sure it includes the telemedicine and the other communication technology-based services that are being used so heavily now during COVID. And they're expanding the extreme and uncontrollable circumstances policy and modifying a bit for APMs. If an APM, now unlike MIPS, if that as a MIPS submitter, you get granted an EUC exception. If you submit data, they forget the exception and score and use the data. For an APM, since there's so many moving parts, if the APM is granted the exception, the EUC exception, if anyone submits data on behalf of the APM or subgroup of the APM, it does not modify or negate the EUC. They're also giving automatic credit for CAPS. So there's no survey for CAPS for the COVID year, and you get automatic full credit for it. We talked about the cost-related changes for COVID episodes of hospitalization. Some other changes in the APMs. Bonus amount is paid on payments made, not allowable charges, which they remind us is also the policy for MIPS. They're having a little trouble finding the tax ID number sometimes for an MPI who has left their APM related tax ID number between the performance and the payment years. So they're published new hierarchy for doing that and a time limitation from the time they start looking provider or their organization is allowed 60 days to lay claim to those payments, and then they're off the hook of needing to distribute those. Like the MVPs, the MIPS value pathway, they're introducing a new APM performance pathway, what they're calling an APP. And biggest news, they're sunsetting the web interface submission method. It's been around since the early years of the program. It's a major method being used, but it's now queued for removal. The proposed date was January 1st of 2021, but they're putting it off for a year, giving you one more year to be able to use it. And with it, they're sunsetting the APM scoring standards, or with the onset of the APP, the APM performance pathway. They don't need the APM scoring standard, which was designed to bridge the gap between the standard APM reporting and the MIPS program for those who are participating in APM but still subject to MIPS. And there are some new scoring rules for the MIPS APMs. The weights haven't changed. Quality accounts for 50%, promoting interoperability for 30%, and improvement activities for 20%. No cost, because cost creates changes in all APMs to their reimbursement levels. So it's already built in. Penalties and benefits are built into the program. All APMs come with a minimum of 50% credit, at least 50% credit for improvement activities. most plans have, or at the moment, all plans have other improvement activities built into their contracts. And Medicare looks at those contracts and then grants additional credit depending on what's built in. Currently, all APMs have full credit for IA. They're also changing the quality threshold, the score, which is the score you need to meet in order to take full advantage of shared savings or avoid a full load of the shared losses. For the first 2 years, that quality threshold is 30%. And for years after 2022 performance year, it will be 40%. So here on the right is a chart that shows the utilization of the 5 remaining submission mechanisms for MIPS. Claims is on its way out. Of course, it was the most used method through the years of PQRS. Web interface has become the most used method since, and that's driven by its requirement for APMs. Now that requirement goes away, they are taking it away. They point out that 80% of web interface users are those APMs, 20% are MIPS groups. It can only be used by a group of 25 or more providers. And they're seeing a couple of reasons they're quoting for getting rid of it. One, its popularity amongst non-APM practices is dropping. 40% reduction in eligibility, 45% reduction in eligibility, 40% reduction in utilization by non-APM groups. And it's also not achieving their goals of making quality measurement automatic or using electronic systems to do it. The most common way that web interface is submitted is with chart abstraction. We've been doing some web interface submissions for clients, and you can do it electronically, except that Medicare gives you a list of patients, and you have to use the top 248 of those patients that are eligible for each of the measures. And it's a pain in the derriere to get Medicare's permission to which patients you're going to use. They have to agree with your list for each of the measures. So it is difficult. I applaud the movement to make all submissions based on automated data. And I think the downside is that by moving it to registry, EHR, or QCDR, you're now responsible for all payers, not just Medicare, not just those 248 Medicare patients for each measure. So it's a trade-off in that way, but I think good overall. I found it's actually less expensive usually to do a chart abstraction for one submission, but if you want to be following your quality month to month and improving that quality, you really need something electronic, and this is moving us in the right direction. I'll be talking more about this program in a webinar in January, so I hope you tune in, give some tips for web interface users to make the switch over. So about the APP, it's styled after MVP. It's operational for this coming year, starting January 1st. Your performance can be measured or will be measured by the APP. You do have a choice of whether your quality measures are the 3 APP quality measures or whether you use the original 10 web interface quality measures. And then after the 2021 year, the web interface is going to be discontinued. Here is the APP, and actually comparing it to the web interface. In the blue box is are the measures that are going to be used for the APP. You can see 6 here. One is CAPS. You'll need a survey vendor for that as usual. There's a hospital-wide readmission measure that Medicare will be measuring and applies to anyone using the APP. There's an MCC, a multiple chronic condition, unplanned admissions category that again Medicare will be measuring, and the active submissions are the ones below. There's only 3 for 2021 for the APP. That's hemoglobin A1C, the screens for depression and follow-up and control of high blood pressure, and they have to be submitted using one of those other 3, EHR, quality registry, or QCDR. If you choose the web interface, you're subject to these first 3 measures just like APP users, and then you actively submit this list. And you see there's overlap. It's the same hemoglobin A1C, depression, and control of high blood pressure. But if you're APP, you don't need to do any of these others. That's about enough to say about that. The advantages, I think they're seeing it as better alignment between MIPS and APM reporting, a lot less confusion for people who may be have a foot in both camps. Reducing the active reporting load from 10 to 3 measures, which is accurate. It reduces the total reporting load from 23 to 6, which is a little bit of sleight of hand, since that compresses the gives you only credit for 1 measure in the as the CAP survey. So it's the same amount of work, but a little less credit. Oh, and newly, with the web interface, if you fail to submit 1 measure, the whole submission is disallowed. But in the new APP, if you miss a measure, you just get a 0 score for that measure, but everything else is scored. It ends that manual complexity of the web interface patient selection, automates quality reporting. Benchmarking, I think this is an important one. The benchmarks will be created across all practices in the US that are using those techniques, not just the web interface. So you'll actually, I think, have more favorable benchmarks for comparison and scoring. New hierarchies, a much simplified hierarchy for handling multiple submissions. If you're in a virtual group and that group makes a submission, that is your final score. Everything else, that's an APM entity submission, a group submission, an individual submission, facility submission, the best score is the one that's used. Oh, and when an APM entity does not have a score, the average NPITN scores are used for across that entity. All right, and we still have a little bit of time for the other interesting proposals in this rule. I'll touch on them, but some of these all of these excite me. Communication technology-based services. Now note, I'm not calling them telemedicine services because telemedicine is a very specific term that Medicare uses that has a very stringent definitions. So particularly telemedicine has to be bidirectional communication in real time using audio and video, and anything less does not count. So anything else, telephone, web visits using secure messaging, anything like that is broadly fits under the communication technology-based services. Those utilization of those services increased dramatically with the start of COVID. You can see about 13,000 claims per week prior to COVID, and in the first few weeks of COVID, it jumped quickly to 1.7 million. I haven't seen more recent numbers than that, but I'm confident that amount has been increasing still. So this has done an important thing. It's broken the ice. Patients are now more likely to be used to it, accustomed to it. Providers are now accustomed to it. Medicare is accustomed to it. Medicare is preparing for this to continue indefinitely. And I think you should too. I think there's some patient convenience issues, some delivery convenience issues that make this a winner. There are 3 categories of codes that have been added to the program. Category 1 codes are added permanently, and that's services that are similar to other existing telehealth services, so they can assume there's benefit. Category 2, someone suggests adding a code and shows evidence that it's beneficial to patients and safe. Those will be added, and there's several of those that have been added. And category 3 are things they've added to keep patients safe and socially distancing. So, and those they expect to drop, but they're also giving us a little time to collect evidence that shows benefit and safety. So they will go away the year in which the end of the year in which the PHE ends. So if the PHE is declared over by midsummer, you can continue to bill for them, use them and bill for them until the end of the calendar year. The list, you should make yourself familiar with them and utilize them wisely and thoroughly. They're to be found here. Those communication technology services are represent care management, principal care management, transitional care management, virtual check-ins, remote physiologic monitoring, psychiatric collaborative care, interprofessional consultation, end-stage renal disease management, and audio-only telephone E&M services. They've been going through the programs, making sure those codes are reflected in CAPS, so we're getting patient feedback on using these services. They're also adding those codes to attribution protocols for primary care codes and to quality and cost measure specifications. The next thing I'd like to draw attention to is electronic prescribing of controlled substances. I think it's about time it gets a little bit more traction. It's in fact required by the Support Act of 2018, and it's required that it be implemented by January 1st of 2021. So we're just days away from needing to use electronic prescribing of controlled substances. Medicare says because of COVID, they'd like to delay. They can't because this is a legislative program, so they don't have freedom, but they can be free to enforce or not. So they don't plan to enforce it until January 1st, 2022. The Support Act and Medicare observes that 98% of pharmacies are prepared to accept controlled substances, electronic prescriptions. 38% of all prescriptions in the Medicare program, at least, were electronic in 2019, and in this current year, 50% are. So they think we're ready for it. Barriers, of course, include EHR capability, identity validation to qualify for making these prescriptions. You need a one-time identity validation, like you do for a passport. And there's two-factor authentication when you log in to submit one of these. And the advantages they see is it should be efficient for your workflows using the same thing that you do for all prescriptions. There's safety and legibility improvements, detection and deterrence of prescription fraud, much easier to detect, much easier to suspect, and it's a prerequisite for a robust PDMP. So hope you can all get on board with that. Now, finally, E&M revaluation, which is very exciting. Medicare had announced their own revaluation program, but then the AMA stepped in with a new set of protocols, new set of guidelines, and instead of implementing their own, they went with AMAs. And I sure wish I had these protocols when I was practicing and trying to learn my way multiple times through the complex set of coding rules. Medicare observes that 40% of PFS charges, physician fee service charges, are or fee schedule charges, excuse me, are E&M visits, and half of those are in the office and outpatient set from 99201 to 99215. So now the changes are being made to that office and outpatient code set, but it also spills over into other codes because many other codes have their values based on the office and outpatient code set. There have been changes in the time minimums for those, and you can either use time or you can use complexity of medical decision making. So it's the same medical decision making that was in the old program, but it drops the history and physical exam requirements, making that only what's reasonable, necessary, and appropriate for the complaint. They're eliminating 99201 and collapsing prolonged times into a single code. So here's a summary of the program from 99211 to 205. The time requirements, if you're billing these by time, it includes preparatory time if there's some contact with a patient before the exam, time your staff spends with them in the exam, and some after, and even some after exam, after visit activity, which may include some data collection and discussion remotely in days after the visit. So I recommend you get into the habit of keeping track of the time for your billing. If you're a little more experienced and more efficient physician, you might make a much better use of the codes using the medical decision making, and there's no reason why you can't go back and forth. Here's the comparison of the old codes with the old time and the new time in the left-hand charts, and the RVUs attached to them, and you'll notice that the RVUs have pretty much across the board gone up. So and Medicare is adding a G2211 code, which is indicating longitudinal care, and they're expecting providers to bill these 90 to 100% of the time. And what it means is if you're addressing longitudinal needs as well as the chief complaint at a visit, that you can add the G2211. So for instance, if a patient sees me for a sore throat, I take a history, do an exam, strep screen, diagnose a strep throat and prescribe, give instructions, that's going to be a 99212 or 3, most likely a 3. But if I put it into context of their other diseases, I see your blood pressure is still under control, you're diabetic, and this may affect, your illness may affect your blood sugar levels in either direction, so check them more regularly. That, or don't forget to come in a month for your flu shot. That kind of activity qualifies it for a G2211. And that contributes to what Medicare expects to be a significant increase in payment for E&M codes. They're also they've also codified G2212 as a prolonged add-on for prolonged time. So if it takes you more time than in the guidelines, this is available to add on to the base code. And all these other services whose values are based on those office and outpatient codes also get paid better now. And that relates to rate setting and conversion factor. The physician fee schedule is supposed to be revenue neutral every year, except for a cost of living increase. Because there's a significant increase in reimbursement for the E&M code set, increase in RVUs, and the use of that whatever it was. There's a compensatory drop in the value of all our RVUs, so the conversion factor is going down by 10%. So there's actually, if you look at the E&M codes, a 15% increased payment for E&M codes averaged across the board, and it's paid for by a 10% reduction for anything you do that's not one of those E&M codes. And that's it for the day. We're open to take questions a couple minutes before the top of the hour, and don't hesitate to submit questions by email if we're not able to get to them in this short time. All payer, will you elaborate? Let's see if I can see this better. For some reason I'm getting here, this might help.
All right, well, thank you everyone for joining us today. Well, Dr. Mingle's reading a couple questions that have come in. Just want to remind everyone that this session has been recorded. We'll be sharing the recording and slides via email later this week. We also do want to encourage you to join our upcoming webinar on web interface and the transition to the other programs, participation options for your organization. And finally, it is the end of the year. It's been a challenging year, and we're grateful to all of you who have supported patients during this global pandemic, and we're here to ease the burden of these programs for you as you're focusing on your patients. So if you are looking for a vendor for 2020 participation or 2021, please do reach out. We are a qualified registry since 2012 and an advisory service with dedicated consultants that get assigned to each of our customers to guide you every step of the way through these programs. So thank you, everyone. We are going to do about 5-10 minutes of questions here. So please do send in questions if you've got them. You can send them via email as well if you don't have time to stick around, or put them in there and we will follow up with you by email if you need to run now. So thank you so much. All right, on to Katie's question.
All right, Katie asks, so will you elaborate on all payer, all patient reporting requirements? Does a shared savings plan ACO Track B basic report on all patients, all payers through the APP 2021 and 2022? And the answer is yes. Of course, the web interface was the top 248 patients in the list, or all of them if there's fewer than 248 patients. For APP reporting, it follows the protocol, the data completeness protocols that registry is always, registry EHR and QCDR have always been following. It's now up to 70% of all eligible instances for all payers. So it doesn't matter who's the payer for your patient if they qualify for the measure. So it's not all patients, only those that qualify for the measure. And you have to reflect at least 70% of those in your report. Now, when you're doing electronic reporting, it's end-to-end electronic reporting, it's assumed to be 100% of your patients. So that's one of the easiest ways to do it. And end-to-end electronic reporting, it's not just EHR. If you're basing it on the direct queries out of the EHR database, it is end-to-end electronic. So now too big to chart abstract, but better in other ways. Jay asks, let's see. For physicians who are no longer with us but have significant data and billing, we need to report about them even if they are already with another clinic for the last part of the year. And the answer is, Jay, yes. Group reporting, whether it's for an whether it's for an APM entity group, or whether it's for a tax ID multi-specialty group or a community system, those reports are blind to the provider. So if the care happened in your institution, in your organization, then it gets reported on. The credit for that does track to the to some extent, depending on the program, to where the provider goes. Amelia asks, for hospitals conducting COVID trials, how do you attest to 50% participation? It would be dependent on how it's being reported. If you're pulling all eligible patients out of your database to contribute that data to the study, then it's 100% of your providers who are participating. If it's just a program that you're singling out for one or a handful of providers, then that would be tracked just to those providers. You'll get more details from the specifications. Maybe there's some exceptions to that, but it wouldn't be something you'd prove by reporting. It would be something you'd prove by the implementation guidelines of the program. Thank you. And then I lost that question here. They've made some changes to go to webinar, and I'm having trouble making this. Oh, there, that's helping. Jay also asks, do we need to report for providers who are affiliated with us and at the same time another clinic? And the answer is yes, but you're not responsible for the data that they generate at that other clinic, just what they do in yours. Evie asks, in the new E&M requirements for time consideration, what can be included in the time? Does the time the nurse spends with a patient before the doctor comes in for the face-to-face, when she's taking down vitals and chief complaint and medication verification, then the time she spends scheduling tests, or is it just face-to-face? Now, I'm going to give you a little bit of a disclaimer on this. Damn it, Jim, I'm a doctor, not a coding specialist, but my reading is that the time that's spent by office staff under the provider's general supervision does count toward these codes. And I'm not seeing any other questions at the moment. So I think that brings us to the end. Again, anything we've missed, anything else you'd like to ask, don't hesitate to email to us. And thank you very much for your time. I enjoyed the time we spent, and have a Merry Christmas, everyone.
Yes, happy holidays to everyone, and best wishes for the new year. And thank you again for joining us. Take care, everyone.